I'm going to start with a little bit about my background. I've been a nurse since 2007, and I completed my PhD in 2020 from the Ohio State University in Columbus, Ohio, in the United States. My research focuses on adipose tissue dysregulation and its relation to chronic systemic inflammation, especially in older adults. The objectives of today's talk will focus on a description of what adipose tissue is and what it is composed of, the types of adipose tissue and where they can be found, normal adipose tissue function, how adipose tissue becomes dysregulated, consequences of adipose tissue dysregulation, and future directions for research. So what is adipose tissue? Commonly known as fat tissue or just fat, adipose tissue is a connective tissue composed mostly of adipocytes, which are similar to the diagram shown here. In healthy weight individuals, adipose tissue accounts for about 25% of total body weight. Historically, adipose tissue had only three functions: to store energy in the form of lipids, provide protective cushion for organs, and insulate for the body. We will touch on recently identified functions in just a few minutes. Adipose tissue, in addition to the adipocytes, also contain many small blood vessels, immune cells, extracellular matrix, or ECM, and stromal cells. There are three main types of adipose tissue: white, brown, and beige. White adipocytes are present in white adipose tissue, or WAT, and are shaped either spherically or as an oval. Inside white adipocytes, there is a singular lipid droplet that pushes the nucleus to the side of the cell and flattens it. These cells also contain several mitochondria. The diagram to the left here shows a typical white adipocyte. Brown adipocytes, which are seen in brown adipose tissue or BAT, are sometimes smaller in size compared to white adipocytes. Instead of a single large droplet of lipids, BAT contains multiple smaller lipid droplets that surround the centralized nucleus. These cells have many more mitochondria than white adipocytes, which gives these cells their brown appearance. The cytoplasm of fat also contains Golgi bodies, endoplasmic reticulum, and a few ribosomes. Fat produces heat and are referred to as thermogenic adipocytes. Beige, sometimes called beet or bright adipocytes, are adipocytes that began as white adipose tissue, or WAT, that have been exposed to a trigger, such as prolonged cold exposure, that causes them to function more like brown adipose tissue or fat. In human adults, the main type of adipocyte or adipose tissue is WAT. That is seen more frequently in babies. With age, the amount of brown adipose tissue continues to decrease until it disappears from most areas. Adipose tissue depots are located throughout the body. Many times, these depots have specific names of reference. For example, visceral adipose tissue, also known as abdominal or belly fat, is located inside the abdominal cavity, filling in the spaces between organs. So to further classify these stores, the adipose tissue that is surrounding certain organs have names that specify this. For example, epicardial adipose tissue is that visceral fat that surrounds the heart. Parietal or subcutaneous adipose tissue is found just below the skin and the hypodermis. Marrow adipose tissue is found in the bone, and its function and importance is poorly understood at this time. Finally, we have ectopic adipose tissue. This is when adipose tissue is stored in other tissue, like the liver or the pancreas. As far as which types of adipose tissue is found where, white adipose tissue is typically seen in periarticular, intramuscular, pericardial, bone marrow, subcutaneous, abdominal or retroperitoneal, and inguinal or gonadal. Beige adipose tissue are found in those locations as white adipose tissue is converted to beige. Brown adipose tissue is continually seen in cervical spine area, the supraclavicular region, around blood vessels, in the axillary area, paravertebral, inguinal, and surrounding organs. As I explained earlier, the historically known functions of adipose tissue included storage for excess energy, a cushion, and insulator. Within the last 20 years, more studies have focused on the newly discovered function. So what's the function? More recently, adipose tissue has been classified as an endocrine organ because it synthesizes and secretes hormones like other endocrine organs. The hormones released from adipose tissue are referred to as adipokines and include leptin, adiponectin, resistin, and cystatin. Today, I will focus on leptin and adiponectin specifically. These adipokines influence many bodily functions, including appetite, insulin sensitivity, inflammation, immunity, and fatty acid oxidation, just to name a few. Normally, adipose tissue seen in lean individuals secretes leptin in limited quantities and adiponectin more frequently. These hormones go on and work to create a state of homeostasis. However, dysregulation of adipose tissue occurs when these hormones are produced in discordance with normal values, and effects are seen in processes throughout the body. Nearly all cells in the human body have receptors for leptin and adiponectin, and leptin and adiponectin have been shown in the literature to be very important regulators of inflammation. Leptin tends to have pro-inflammatory actions, and adiponectin tends to have anti-inflammatory actions. So when adipose tissue is dysregulated, leptin and adiponectin production is altered, and inflammation is then affected. There are some differences in the amounts of hormones produced by the varying types of adipose tissue. For the remainder of the lecture, I'm going to focus on what is typically seen in white adipose tissue. In lean individuals, adipose tissue is composed of small adipocytes with few macrophages. In obese individuals, adipose tissue is composed of large adipocytes with many macrophages. You may remember during classes on immunity, macrophages increase inflammation and stimulate the immune system. So as we look at the two diagrams here, we see several main differences when comparing adipose tissue from obese individuals to that from lean individuals. First, the size of the adipocyte is larger in obese individuals. Second, the number of macrophages present has increased. And third, inflammation has increased. Adipose tissue continues to produce adipokines, but the levels of adipokines have changed. Leptin production increases and adiponectin production decreases. The result is increased inflammation without a pathogen or injury that inflicted damage. This type of inflammation is referred to as sterile inflammation or chronic systemic inflammation. This slide shows the currently known reference values for leptin and adiponectin as indicated by the Mayo Clinic in the United States. Please note that for leptin, the only known reference values are for a BMI of 22, which is a normal weight. All other BMI values are unknown, partially due to the effect of obesity on leptin production. As you can see by the adiponectin reference values, as BMI increases, it is expected that adiponectin levels will decrease. Several previous studies have suggested that the amount of leptin relative to adiponectin, or the leptin to adiponectin ratio, commonly referred to as the LAR, may be a more valuable tool in determining inflammatory actions or total status than considering the values of leptin or adiponectin in isolation. Higher LARs are thought to be indicative of greater levels of systemic inflammation. Thus, the LAR may be helpful in predicting risk for diseases with an inflammatory component for the purpose of implementing preventative interventions. Reference values for LARs have not yet been established. However, LAR cutoff values for determining increased risk for some disorders have been reported. In a 2018 study by Larson and colleagues, individuals with LARs above the cutoff values were up to 8 times more likely to have metabolic disturbances like insulin resistance, leptin resistance, or delayed triglyceride clearance than those with LARs under the cutoff values. For example, the study showed that LARs higher than 1.36 for normal weight individuals and higher than 3.65 for obese individuals were believed to indicate great increased risk for pathologically delayed triglyceride clearance, Similarly, LARs higher than 2.2 may indicate pathologic insulin resistance. However, an LAR of 1.88 and higher was associated with a 48 times higher risk of having at least two of those three metabolic disturbances. In terms of inflammation, given that higher LARs are associated with more inflammation, it may be important to reduce high LARs to help treat and/or prevent inflammatory conditions. Of the studies that included measures of leptin to adiponectin, very few included the leptin to adiponectin ratio. Interventions that have small effects on leptin adiponectin individually may have significant effects on the LAR. Adding the LAR calculation to future studies is important to compare this metric across samples. This calculation can be easily completed by dividing the leptin in nanograms per milliliter by adiponectin in micrograms per milliliter. It's known that leptin and adiponectin levels are influenced by a variety of factors. The exact mechanisms of these interactions are not well understood at this time. However, factors like age, sex, BMI, chronic diseases, sex hormones, medications, and socioeconomic status have been shown to influence levels of these inflammatory mediators. So what? Why does it matter if someone has altered adipokine levels due to obesity? Some consequences include increased inflammation, insulin resistance, dyslipidemia, increased thrombosis, atherosclerosis, and cellular proliferation, which in turn leads to increased risk of chronic diseases such as diabetes, cardiovascular disease, hypertension, depression, arthritis, and cancer. In some cases, chronic systemic inflammation begins with increased pro-inflammatory cytokines after stimulation from stress or toxins. This leads to increased adiposity, which, as we've already shown, leads to more increased pro-inflammatory cytokines. Both inflammation and obesity lead to chronic diseases. This results in a cycle of increased adiposity, increased inflammation, and increased risk for chronic diseases. This makes it very difficult for interventions directed at any of the three physiological states alone to be successful. This is also a contributing factor when we see overweight and obese patients that have increasing numbers of chronic diseases as time progresses. According to the Centers for Disease Control in the United States, nearly half of all U.S. adults are considered obese with a BMI of 30 or higher. 9.2% of all U.S. adults are considered severely obese with a BMI of 40 or higher. These numbers are expected to increase each year. However, this is not just a U.S. problem. The World Health Organization reports that the number of people who died in 2017 alone, where increased adiposity contributed to their deaths, was more than 4 million people. In some places in the world, the rate of obesity has increased more than 30% in just a few short years. And now this epidemic is reaching our children and adolescents. The World Health Organization estimates that from 1975 to 2016, the number of overweight or obese children and adolescents, that's those aged 5 to 19 years old, have increased from 4% to 18%. That's more than a four-fold increase. And in 2020, 39 million children worldwide under the age of 5 were considered overweight or obese. We can expect this will lead to increasingly common chronic diseases being diagnosed in younger and younger patients. So what does all of this mean? For healthcare providers, assessments for obesity should be conducted. Additionally, education should be provided to patients, family members, and other members of the healthcare team about the role adipose tissue dysfunction plays in chronic disease risk. Being overweight isn't just a weight issue anymore. It's an inflammatory process that encourages chronic disease progression. Additionally, assessing for the presence or risk of chronic diseases is important in obese populations because they are at higher risk. We need to identify current risks to help patients live healthier lives. Perhaps most importantly, inflammation has been shown to increase adiposity. So we need to remember, once this adipose tissue dysregulation begins, it is very difficult for weight loss to occur. Together, healthcare providers and their patients can collaborate in making appropriate goals and in planning the necessary steps to meet those goals. As far as future research goes, including the measure of leptin and adiponectin inflammatory studies may add valuable information to this process. Observational studies that assess the interactions of leptin and adiponectin with other hormones and markers will aid in the determination of the pathobiology involved in chronic diseases. Additionally, intervention studies focusing on improving leptin and adiponectin levels would be beneficial in slowing disease progression, preventing new diagnoses, and lowering disease risk. Now, I have to say I'm not a bench scientist, so I applaud those of you who are and admire your work greatly. But it is really on your shoulders to help push us into the future so we can see exactly what is causing the leptin adiponectin dysregulation and exactly what happens after that. In summary, we know that adipose tissue dysfunction leads to abnormal levels of leptin and adiponectin. We know that leptin and adiponectin influence inflammation and chronic diseases. But the leptin to adiponectin ratio may be more accurate at determining inflammatory status than leptin or adiponectin alone. That covariates such as estrogen, testosterone, and medications influence leptin and adiponectin production. And that intervening to improve leptin and adiponectin levels may prevent or reduce the risk or symptoms of chronic diseases. However, there's still a lot we don't know. We don't know the reference values for all ages and BMIs for both sexes for leptin, adiponectin, or the leptin to adiponectin ratio. We don't know the extent of which and the exact mechanisms that covariates influence leptin and adiponectin production, or if leptin and adiponectin levels correlate in different human biological substances like hair, urine, saliva, which might make it more easy or convenient to recruit younger individuals. We don't know the optimal dose and duration of interventions, such as EPA and DHA, a known anti-inflammatory intervention, for improving leptin and adiponectin levels. So with these facts in consideration, I propose future studies should examine adipose tissue dysregulation, specifically leptin, adiponectin, and the leptin to adiponectin ratio, and chronic diseases with an inflammatory component, such as diabetes, cardiovascular disease, arthritis, cancer, and dementia, just to name a few. Thank you again for joining me today in my discussion of adipose tissue dysregulation. Again, my name is Dr. Jamie Rausch from Indiana University, Fort Wayne, and you can reach me at the email on the screen. I would be happy to answer any questions that you might have. Thank you very much, and enjoy the rest of the conference.